Just a really quick introduction, because this Lunch and Learn is hosted by East Genomics. Just wanted to make you all aware that we have the 7 genomic medicine service alliances across the country, and we are the East of England, so that covers East Midlands and East Anglia. And we work together with the East Genomics Laboratory Hub. So together we formed East Genomics, and we aim to ensure that there is that eligibility of patients to genomic testing, and ensure that there is that equity of access. And we want to ensure that we support the establishment of testing pathways for cancer and rare diseases, as well as supporting clinicians with requesting genomic tests. And that's why we put on some of these Lunch and Learns, so that we can support you through those processes. This is just a really quick map to show you where we cover. So I'm Jo Hargrave, the lead midwife for the GMSA, and we have multiple clinical professionals who support the embedding of services. And we've also got 3 laboratory sites as well. The National Testing Directory, if you are not familiar with this, this is a centralised service whereby it outlines the range of genetic tests that are commissioned by NHS England, and it shows you what the most appropriate test is for each clinical indication, and it also tells you about the patient eligibility, so that criteria for testing, and also who should be ordering these tests. So again, this is why we are talking about sudden cardiac death, and this has been a transformation project which is prominent across all GMSAs to increase the access of genetic testing for families who have lost loved ones to sudden cardiac death, with the aim is to reduce the number of SCD deaths in the UK. And this project aims to develop an integrated pathway that enables all families affected with SCD to access genomic testing on stored tissues and DNA when it has been suspected. So this has been going on for a while now. However, the project is now bringing in more coroners, and funding has been agreed to resource coordinator roles to ensure that genetic materials are retained at post-mortem for those people who do die suddenly. And then that means that families can be referred for screening. And ultimately, the aim is to move this from a pilot project to business as usual. Excuse me. Now, in the East, the service is live at Leicester University. And if you do want to know more about this project, you can visit our website, and hopefully Ian can pop that into the chat as well for further information on that project, but also for the relevant contacts for that project as well. So I think that will lead me nicely into Chloe. Oh, let me just go here. So Chloe Ferguson is a clinical nurse specialist for inherited cardiac conditions, and she's going to provide that overview of sudden cardiac death. So thank you so much, Chloe, for supporting this.
So thank you for inviting me to do this little teaching session. So I know there's quite a broad range of people attending from different professions within the NHS. So I've tried to kind of tailor it so it will fit everybody. So if I don't go into as much detail as you are hoping to, I do apologise, but more than happy to have some separate catch-ups, maybe even put together some separate teaching sessions for at different times, different levels and things. So the title of my presentation is Inherited Cardiac Conditions, but we will be talking about sudden cardiac death due to those conditions mainly, as well as talking about the other aspects of inherited cardiac conditions as well. So a little bit about myself. I've been a nurse for 8 years. I've always been within cardiology and always been within acute care mainly. The last kind of a few years I've been CCU, and then last year the opportunity came up to develop the ICC Nurse-led services at UHL. So I kind of jumped at the chance and went for it. So that's what I have been developing here at Glenfield, developing the adult service, but working quite closely with the paediatric team, the genetics team, to pull together a well-rounded holistic service. So next slide, please, Jo. So I will be talking about what inherited cardiac conditions are, and then when we're talking about these conditions and talking about deaths that have happened, there are often acronyms of SUD, SCD, SAD. We'll talk about what they mean, how they do actually mean different things, but we'll come on to that and how it gets a bit confusing. I'll talk about my role. Often I'll be confused with a congenital nurse specialist, and I don't mind that, but we are different. The conditions that we look after, the genetics, the testing, and the genetic counsellor's role. And then I've got a couple of cases to go through, because I think it's quite nice to discuss these kinds of things with a case in mind. Sometimes it helps know what actually goes on and what we actually do. Talk a bit about family history, and then just the resources I've used to put this together. So next slide. Yeah. So ICCs are a group of conditions that can be inherited, and they affect the heart, whether that be the heart muscle or the conduction system of the heart, or the major blood vessels that are coming away from the heart. So each of these diseases can be life-threatening, and although sometimes a person, or most often a person, will have some symptoms that will lead to investigation and then lead to a diagnosis, unfortunately sometimes the first sign of one of these conditions is either a sudden cardiac death or a sudden cardiac arrest in somebody in a family, which then leads the family with that tragic loss of a young person, and then having to go through the whole process of finding out what it was that caused their cardiac arrest or sudden death, and then what it means for the rest of the family, and actually does it mean that more people in the family are at risk and might have a heart condition as well. So next, this kind of drawing on what Jo's mentioned about the sudden cardiac death pilot. So this quote at the top here is, every week in the UK, 12 young people, so that's people aged 12 to 35, die due to an undiagnosed genetic heart condition. So there are more sudden cardiac deaths than that, but this is kind of focusing in on when it has been caused by an underlying genetic heart condition, like a sudden arrhythmic death or due to a cardiomyopathy. So down in London, there is Professor Mary Shepherd, who put together a paper to support the pilot project, and studied the in her pathology unit, they examined 7,400 hearts between 1994 and 2021. So of these were, sudden cardiac or sudden unexpected death cases. 242 cases were excluded as they had a non-cardiac cause. So that left 7,214 cases with a cardiac cause of death. From these cases, 75% of these deaths had a cause linked to an inheritable condition. 53% were caused by SADs, and 22% were caused by cardiomyopathy. So this kind of just highlights how important it is to be aware of these conditions, and to know what to do with these families and for these individuals when something like this is suspected. And these weren't kind of all of the deaths, all of the sudden cardiac deaths that happened within that time frame. That's just, the ones that were picked for this project. And then the next slide. So this kind of just highlights that when we focus on those that were caused by a cardiomyopathy, the most common is idiopathic hypertrophy, so thickening of the heart muscle. And then from the cardiomyopathies, there isn't much outruling the other. They're all kind of a similar percentage of the prevalence of them causing a sudden cardiac death. So next slide, we'll go on to discuss these acronyms. So these acronyms they do have different meanings really. So they do get used interchangeably, which can be confusing. So SUD is sudden unexpected death. So this is not always a cardiac death, but it might raise suspicion of a cardiac cause. So for the pilot project and in the paper that I've just mentioned, a sudden unexpected death is witnessed with and the person has died within 1 hour, or if it was unwitnessed, they were last seen alive less than 24 hours ago. A sudden unexpected death would prompt a postmortem and coroner investigation. And then with SCD, this is sudden cardiac death. So sometimes a sudden unexpected death will immediately be labelled as a sudden cardiac death because of the circumstances. So, and in one of our cases, it was kind of that we'll discuss shortly, the death was immediately labelled as sudden cardiac death because it was so suspicious of how that person had the cardiac arrest and passed away. Or it might be that the sudden cardiac death is ruled at the post-mortem because a cardiac cause is found at post-mortem. And these are the cases where it will trigger investigation for the family, and it would trigger a molecular autopsy. So it would trigger genetic testing on stored samples from the person who has passed away. So that is most often a spleen sample. And then SAD is sudden arrhythmic death. So when there is a post-mortem carried out and the heart is looked at, it might not identify any structural abnormality. And that means that nothing specific has been able to find at that post-mortem stage. When someone has died because of an arrhythmia, there will be nothing structurally wrong with the heart. So based on circumstances of the person passing away, and we can do that molecular autopsy and genetic testing as well, would lead us to rule it as a sudden arrhythmic death, because there hasn't been anything specifically found on the heart that could cause that cardiac death, but there are no other causes identified. All other causes have been ruled out, so we can label it as a sudden arrhythmic death because that is the most likely cause to have happened. And I think so. Family investigation after all of these things. So after sudden cardiac death, if we have been able to find a specific cause at post-mortem, we can tailor the family investigation to specific investigations of ECG, of echocardiogram, of MRI. If there has not been a specific cause found and we have a sad death in a family, there is kind of an array of a workup of investigation. So we're looking at the channelopathies then, and we would need to do investigation to rule out all of those in the relatives of that person who has passed away. Next slide, please. So the role of the ICC nurse in all of this. So I will provide condition counselling for people who have a diagnosis of an inherited cardiac condition. I will do family screening. So I have a weekly clinic where I screen the families, so first-degree relatives of someone who has a condition. I carry out diagnostic genetic testing in a weekly clinic. So those who have a diagnosis, I will talk to them about undergoing diagnostic genetic testing, what it means for them, what it means for their family. We will liaise with the cardiac genetics MDT. So we have a twice monthly cardiac genetics MDT, and that is discussing most of the sudden unexpected death cases will go through the MDT. Mainly, a lot of the time it will be for support as well. This can be quite challenging when these cases happen. Sometimes quite emotive, so it's good to be able to have that team support for these cases, and to know and feel strong that you are doing all of the right steps for the family, looking after the family to try and help them and support them. We'll do a lot of liaising with the coroner team to find out about postmortems, if any samples have been saved. Work very closely with the clinical genetics team and the genetic counsellors. We have a service phone line, a service email, and then we will triage referrals. So the referrals will come in. I don't triage all of them. They're done by the consultant and by me. So the referrals come in via a PRISM pathway from the GP. They come from genetic counsellors, other genetics team, and they might come from other cardiologists as well within the department. Next slide, please. Okay, so when we talk about inherited cardiac conditions, and when we were talking about sudden cardiac death and sudden arrhythmic death, we can kind of, I mainly separate these conditions into the cardiomyopathies and the channelopathies. So your cardiomyopathies are affecting the heart muscle, and it can be dilated, so the heart becomes thinner, bigger, baggy. Hypertrophic cardiomyopathy, the heart muscle becomes thinned. There's myocyte disarray, so the cells become disorganized. And then arrhythmogenic cardiomyopathy, similar picture to dilated cardiomyopathy, but there is a lot of scar within the muscle wall of the heart, and the person might be experiencing more arrhythmias. They're very pro-arrhythmic in these cases. And then there are the less common heart muscle problems like left ventricular non-compaction. It's not always an inherited cause, and restrictive cardiomyopathy and cardiac amyloid. They're just kind of the lesser common ones that we see often. And then the channelopathies are Brugada syndrome, long QT syndrome, and catecholaminergic polymorphic VT, CPVT to make it easier. So Brugada syndrome, or long QT, CPVT can all cause these cardiomyopathies as well can all cause sudden cardiac death. The CPVT is usually exercise driven. So a lot of the time when there have been people who have passed away during exercise, I'm really sorry if you can hear the food van in the background. It should disappear as quick as it comes. Sorry if you could hear that, it's very loud. So the CPVT is usually when people have passed away during exercise, collapsed on a football pitch. And long QT syndrome, there are different types, and Brugada syndrome is quite a classic that a lot of people are aware of already. You can't talk about inherited cardiac conditions without mentioning aortopathies and the neuromuscular conditions. So aortopathies are your kind of Marfan syndrome, aortic aneurysm syndrome, and they should be mentioned because they can be, especially the aortic aneurysm syndrome, can be a big cause of these sudden cardiac deaths, and we do see them come through the pilot. So although they're not kind of within my particular speciality here at Glenfield, we do screen these patients. We just don't have a dedicated person who is specialised in that area, but we will make sure that those families are screened and are seen by the right people and looked after. Okay, next slide, I think. So kind of treatments of young patients with inherited cardiac conditions. This slide is from a presentation by Dr. Dutia, who I work with closely. He's the lead consultant for inherited cardiac conditions. So I know we're kind of talking about the sudden cardiac death and the causes and how to know what to do in those situations for the families, but it's important to know that there are many people living with these conditions as well, and what the treatment is aimed at for these patients. And it is a lot about lifestyle, so they will be receiving a huge life-changing diagnosis, and a lot of the time it will be about taking a whole load of new medications, changing some lifestyle factors that are better suited for them, healthier, but also sometimes we might be talking about exercise. So if someone is doing lots and lots of exercise, we might need to not tell them to stop doing exercise. We never want to do that, but just tailor it to a way that is safe for that person. And then there aren't any major surgeries, procedures that can take these conditions away. We're not going to be able to do anything to take it away from the patient. With the hypertrophic cardiomyopathy, so the heart muscle thickening, there are major surgeries to reduce the bulk, and there is a new medication as well that can help reduce the impact of that thickening on the heart for the person, so they are less short of breath. And then we obviously talk about defibrillators and ICDs for these patients as well. We don't want to put an ICD in everybody. A lot of the time when I talk to my colleagues, they're very surprised when they talk about a patient and they think, a family history of Brugada or a family history of CPVT, and they don't have a defibrillator. But the risks of having a defibrillator and inserting a device in somebody, if there is no risk to that individual person, it far outweighs the benefits of having it there just as a safety net, because if they actually don't have any risk factors other than a family history, it might be that that's not the most appropriate line of treatment. And you might be causing more harm, because it's a huge psychological burden to have an internal ICD defibrillator as well. Okay, the next slide. So this is kind of talking about moving on to the diagnostic genetic testing for these patients. So it's like a book is normally how this explanation starts, and these are the conversations we will have with individuals and with families. So if there is a family who have gone through losing a loved one because of a sudden cardiac death, and we are wanting to explore diagnostic genetic testing to see if we can find the underlying gene that has caused that condition for that person, we will start to talk about diagnostic genetic testing. So I don't know how much detail to go into this right now, because I know we've got quite an array of attendees, and knowledge is will be quite different. But essentially, our genes are like our instructions, and we have particular instructions that will tell the heart muscle how to behave, the structure how to develop. If there is a mistake on one of those genes, this heart cells can't read that instruction properly, and then it might develop a problem with the heart structure, so the cells might not be able to stick together as they should. There might be a problem with the channels, the sodium channels, and letting electrolytes in and out of those channels if there is a mistake on that instruction for the heart cells. So we discuss with patients that we can start to investigate the genetics of the person who has passed away, to see if we can find that underlying genetic cause. It's important to tell them that we might not be able to. The yield of doing this is not huge. So it's really important to explain to patients that a lot of the time they're undergoing this to try and find an answer why their loved one has passed away, and we might not actually be able to give them that. Sometimes it can lead to more uncertainty or just confusion a lot of the time. But when we do find an underlying genetic cause, it means that we can use that information for the rest of the family to see if they are at risk of developing an inherited cardiac condition. And then there are many other things that it can help with family planning, screening of younger children, and things like that. So if we go to next slide. This was just a bit about genetic testing. So the diagnostic genetic testing I do in my clinics as a simple blood test, and it's the panel testing that I do. If I find something and then the wider family can have predictive testing, we will give them letters to be referred into the clinical genetics department so that they can talk about predictive testing, because there is a lot that comes with predictive testing and finding out if you carry a genetic alteration when actually you don't have anything clinically amiss. It can be sometimes difficult to sit with, and actually a lot of people, which is surprising for some people, they don't want to have predictive genetic testing. And of course they are categorized from benign through to pathogenic, so we're talking to people about each of these. So we discuss the uncertainty, the likely pathogenic and the pathogenic. We will discuss that with our family, with the families who we see and the individuals that we see with the diagnosis. So I think next we're going to move on to some cases, but I didn't know if there was any kind of questions at the moment. If anyone wanted to ask something about what I've already discussed. Okay, I don't think anything is popping up in the chat or any hands up, so I'll move on to our cases. So first we're going to discuss a family history of arrhythmogenic cardiomyopathy. So here where the arrow is pointing to the person who was born in 2004. So I just want to add a note that I've kind of removed all of the information about these patients and actually changed the ages as well, slightly, just so that for protection of those patients. This 19-year-old female has a family history of arrhythmogenic cardiomyopathy. It's in her mum and then also in her maternal uncle. So those are the two people highlighted in the kind of bluish colour, light blue colour. It was first identified in the uncle and then identified in mum. So she came to me with this information. My mum and my uncle have arrhythmogenic cardiomyopathy. So for this individual, we can do her clinical screening. So that is the clinical investigation of ECGs and echocardiogram to see if there is any electrical abnormality or any structural abnormality with the heart. I then delved a little bit deeper and with this information, we started to talk about if any genetic testing had been done or if it would be able to be done. So on the next slide, we have the National Genomic Test Directory. So this is what I use for all of my patients when we are considering diagnostic genetic testing. So the findings of dilated cardiomyopathy on its own won't necessarily immediately be able to qualify someone for the diagnostic genetic testing. But what we did find out about this family, if we go on to the next slide, please, is that mum has an ejection fraction of 40% on her echocardiogram and she has a CRTD. So we can assume that she has some arrhythmia problems and disturbances. And then her uncle has severe heart failure, so likely a low ejection fraction, and also has a CRTD. So we can also deduce that he's having some arrhythmia problems as well. So if we flip back a slide, sorry Joe, there's a bit of flipping back and forward, back to the National Genomic Test Directory. The patient who came to see me, her mum actually qualifies for genetic testing in a number of these criteria. So she has a reduced ejection fraction of less than 45%. Her age of onset is below 65, and she has also got some ventricular arrhythmia, and she has a first degree relative with a confirmed diagnosis of arrhythmogenic cardiomyopathy as well. So she does qualify for diagnostic genetic testing. So I then delved a little bit deeper, and when you start getting more of the family coming to the appointments and start investigating the diagnostic genetic testing, because obviously mum would have to be referred for me to then investigate into her. If you skip down 2 slides, Joe. we then have this picture. So the mum and uncle are have had genetic testing, and they are gene positive. The maternal grandmother initially declined predictive. She also has a diagnosis, but she initially declined predictive screening, and then a bit later in life, she's started to, you know, fall a bit poorly and had some investigations, and she was also found to have dilated cardiomyopathy. And then the sister of my patient who I saw, she also had predictive genetic testing and was found to carry the gene. She went on to have a daughter who has the gene, and she also developed cardiomyopathy as well. So in this family, we've been able to, even without the genetic testing, we know that there is a familial inheritance because there are multiple members in the family who are affected by this condition. We know that it is autosomal dominant because it was in grandmother, and then it is in my patient's mum, and we know that it's not X-linked because it's affected both men and women. So the importance of screening in families is really high here. Knowing this genetic information, we spoke to my patient, and the next steps for her were to the next steps for her were letting her know the pathways she can go down. So supporting her through the decision of having predictive genetic testing if she wants to. So if she had the predictive testing and had a positive finding, we would increase the frequency of her screening, and we would talk to her about reproductive options. So knowing that you carry a genetic alteration for one of these genes, a pathogenic alteration, means that you can have a type of IVF where you avoid passing on the gene to your children, or there are other types of testing that can be carried out through pregnancy as well. Of course, if you didn't want to go through those avenues of reproductive options, we just know that we need to screen the children that she has as well. If she's gene negative, she can be discharged. There's no need for her to have clinical follow-up and have clinical screening to continue. And if she doesn't want to have predictive testing, we would still continue with the clinical screening. You know, as I mentioned before, it is quite normal for people not to want to have predictive genetic testing. I have quite a lot of patients who have that they know that they can have it, but they would rather just stick with their clinical screening for now. Quite often it's with younger patients, they would rather just not know and just actually, oh, I'm doing my GCSEs, now I'm doing my A-levels, I'm about to go off to uni. There's too much going on for me right now to find that information out as well. And they know that at some point it might play a bigger part in their future, especially with family planning and things like that. But for right there, it's just not something that they want to have at that moment in time. So my next case, if we go to the next slide, please, Jo, is a SADS case. So again, details have been changed slightly. So this was a 17-year-old male, and he had a sudden collapse whilst playing football. He had CPR commenced and also had a defib attached. He was brought to hospital, but unfortunately he was not resuscitated and he passed away. So this is someone who had a sudden cardiac death, and as I say, it was labelled as almost immediately sudden cardiac death because they collapsed whilst exercising, young, and the defib was attached, and shocks were attempted, so that would tell us that there was an arrhythmia. So this was kind of already labelled as a SADS case or a sudden cardiac death. So if we go to our next slide, this will go through what happened with this case and with the family. So as I say, it went from sudden unexpected death to sudden cardiac death almost immediately, pretty quickly, because of it being a witnessed cardiac arrest. And as I say, that an AED, a defibrillator, was attached and shocks were attempted. So this would raise a high suspicion of a cardiac cause, and the coroner would request a post-mortem. At post-mortem, there was no structural abnormalities found of the heart. So the heart would have been weighed. They would have looked at the tissues and the cells very, very closely to see if there's any kind of what we call myocyte disarray, if the heart is heavier than it should be, anything like that. And there was no structural abnormalities. So this rules out a cardiomyopathy being the cause at this stage, but it cannot rule out a channelopathy, so, you know, Brugada, CPVT, long QT, as there wouldn't be any evidence of this on the post-mortem of the heart. What happened next is molecular post-mortem, so genetic testing of the deceased. So usually a spleen sample is sent for genetic testing, and it's the next of kin that all of this process goes through. So the family will be brought in for genetic counselling, discussion of genetic testing, and what we might or might not find with the deceased results. In these cases, it's at this stage where the family will also be referred for clinical screening. So for clinical screening of a SADS case where a cardiomyopathy has been ruled out, we will still do a kind of a full workup, as we like to call it. So we will do an ECG, we will do imaging of an echocardiogram first, and then we will also discuss the types of testing that we can do to rule out the channelopathies. So to rule out a Brugada, it would be ECG with different lead positioning and then an Ajmaline test. And we can also do testing for CPVT. We can do an exercise test. And seeing as this patient passed away whilst playing football, it would be reasonable to do an exercise test for the family members to see if they have any signs of CPVT. Sometimes in the cases, it is very, very unlikely for it to have been a CPVT cause. Maybe someone's passed away at rest or during sleep. Then we wouldn't necessarily always do an exercise test for the family members. Genetic testing. The reason we do the screening alongside the genetic testing is a few reasons, really. One of the ones is a main reason is for reassurance. You know, these families have just lost their 17-year-old son, brother, and it is worry that takes over that it's going to happen to someone else in the family, as well as having to deal with the loss of that young person so tragically. So being able to do the clinical screening alongside the genetic testing just gives that added reassurance that we are looking for anything else in your family members, and we are making sure that we are keeping you as safe as possible. With genetic testing, it can take up to 6 months, sometimes a bit longer. So waiting that long length of time with those anxieties can be quite hard for families. So again, reassurance of knowing that we're doing some clinical investigation of the family members. When we get the results back, if there is any genetic results that can lead to predictive genetic testing, at least that family knows that they've already had their clinical screening. So they either unfortunately know that maybe I have got a condition myself, or okay, even if we find a gene, I know I've had my clinical screening and actually everything's okay right now. So this family, whilst waiting for the genetic testing, had the clinical screening, and then eventually when the genetic results were back, it identified a gene that was associated with CPVT. So for this family, we managed to find a cause for their son, their brother's cardiac arrest whilst playing football. And on the next slide, please, Joe. Thank you. It kind of just puts together what then happened in the family for the predictive testing. So we offered predictive testing to the wider family. The gene had come, he'd inherited it from father, and his brother had also inherited that gene. So what we can do now is support that father and that son, knowing that they have CPVT, supporting them to live as normal life as possible. And also it means that if the deceased's brother, if he wanted to go on to have children, we would be able to discuss predictive PGT, so the form of IVF to avoid passing on the gene. So in these cases, that is most often when people might use that kind of service, so that especially when there has been such a young sudden death in the family, they might be quite concerned about any future family planning for them. In this case, we wouldn't tell the brother that he needs to stop exercising. Of course, we would do exercise tests to see what his heart rate and rhythm is doing during exercise, and we would just make him very, very symptom aware. And in these cases, it's really important to start the discussion with friends, family of CPR, because ultimately that is what is going to save these people. We can do all of the screening and we can do all of the genetic testing, but if the individual has a cardiac arrest, it is CPR that is going to really save these people's lives at that point. Knowing that he has CPVT now, we can do some exercise prescriptions, and they are always a shared decision with our patients, and we discuss the types of exercise that are safer or safest to undertake, and how to warm up, cool down, and those types of things. So that was the sudden death case to discuss. My next slide, it just talks about the aspects to consider when you're discussing family history with your patient. So I think a lot of the time I thought I was really good at asking about family history. Even when I had, before I took on this role, I was very interested in inherited cardiac conditions. So I always thought I was quite good at asking about family history. However, are we asking all of the right questions? So it's really important to know if there are any sudden unexpected deaths in the family, and also what were they doing at the time? Is that going to help us and give us a clue of how that person passed away? Are there any survived cardiac arrests? Because we always ask about any sudden unexpected deaths, but I never used to ask about, has anyone survived cardiac arrest in the family? And if they have, we ask about the sudden unexpected death, but the person you're asking might not say, well, no, but someone did survive a cardiac arrest though. Sometimes it might take you asking that question. And then this is a tricky question, but I try to always ask. I won't always ask, but I will try my hardest to always ask about suspicious deaths. Has there been any drowning, any car accidents? Because we do know that sometimes it can be that someone has had a cardiac arrest in water, or maybe they've had a cardiac arrest at the wheel that has led to a car accident, or that has led to what we thought was a drowning. But one of our sudden cardiac death cases was somebody who was very, very elitely trained in swimming, was out in calm water and passed away, and it was initially ruled as a drowning, but the circumstances just led us to not quite believe it, and investigate the family further. Has there been anyone with a pacemaker at a young age? Sometimes that might get a little bit missed or ignored if we don't ask that specifically. And also there might not be any family history, but these genetic alterations, these familial conditions, they've got to happen for the first time somewhere, sometime. So actually there might not be any family history, which sometimes leads you to think, oh, it's not anything familial, but it has to happen for the first time somewhere. My next slide is about the conditions and the frequency of screening. So this is for adults, but usually when there is a family history of any of these conditions, the rule of thumb is that there isn't really any. We have to kind of go, there isn't any prescribed, any, you know, guideline advice for when to do screening. So different centres will do it differently. In Leicester, we tend to go with the advice of whatever age that child is in the family. If they are a first degree relative, they should be screened at that age, you know, whether they are, if they're less than a year, perhaps waiting until they're a year old and able to tolerate these investigations, but investigate them at that age, and then regular screening to start it sort of for the cardiomyopathies around 10 to 13 years old. For the arrhythmias, we would probably screen from younger, just because we know the prevalence in younger children can be quite high, whereas in cardiomyopathies, if you've done a one-off screening at say 3, 4, 5 years old and everything is okay and they don't experience any symptoms, starting the screening at 10 to 13 is very reasonable, the regular screening, and we would do that yearly until they are 21 years old, and then if all the screening has been normal, we would do it less frequently, maybe every 3 to 5 years. I think I have one more slide about the ICC service at Glenfield. So that's our email address at the bottom there. And we have a dedicated outpatient service. So there is myself doing the 2 nurse-led services per week, and then the consultant doing obviously the consultant-led clinic every week. And we have integrated care with a one-stop clinic environment. So our patients will come in, have ECG, echo, and see me on the same day. Sometimes we'll be able to do genetic counselling on the same day that they see the consultant for one of their follow-up appointments. Transition services, we're working very closely with the paediatric services to ensure a smooth transition of these patients who either have a condition or are undergoing their screening. We try and get involved in education as much as possible, like today, and we would love to be able to put on more sessions, really. You've probably noticed I'm quite unpracticed at education and providing these services at these talks, especially virtually. It's really quite strange actually to be sat here in a room talking to my computer screens. So yeah, hopefully I've been able to manage it fairly well, and we can only get better with practice. So, and we have a good patient and public engagement. So really important to mention that the Joe Humphreys Memorial Trust is a local charity and memorial and trust that was set up in memory of a young teenager who passed away suddenly. And his parents set up the Joe Humphreys Memorial Trust. Their main focus is getting defibs out into the community and teaching CPR to community groups or anyone who is willing to learn and wants to bring that teaching to their, you know, club community. And they also funded the first year of my role, which allowed me to create the service here at UHL. So yeah, huge. I can never do these sessions without mentioning them. And they have some good resources available for patients as well, if you have any patients who themselves have an inherited cardiac condition or a family member. And that is about everything, I think. Just my resources there that I use to create the PowerPoint. So happy for any questions or discussion if we have time. Thank you very much.
A couple of final sort of presentation, I suppose tie up the conversation, is that there is now a resource on GNotes that can support people who are working in cardiology. This is actually a new collection amongst a lot of other GNotes resources, so it's not just for cardiology. There are maternal, fetal medicine and endocrinology, but this I think started about a month ago. But basically it's created by clinical experts and aims to meet the wide spectrum of genomic education needs for those busy cardiologists and nurses and midwives, in fact, actually, for what tests to order. and also sort of thinking about inheritance patterns and I think it's got about hypertrophic cardiomyopathies and bits and pieces, so specific clinical scenarios, and you can then extend your learning. So they've got lots of resources available on there. Ultimately, you have that if it's within the clinic and you've got that patient in front of you, it can help support you at that point. Or if you go away after this session and think, oh, I really want to learn more, then do head over to GNotes. And then finally, probably back to Ian, I would say, but we've got a few QR codes that link you up to our newsletter, and we do provide updates on a regular basis on different events that are happening. We've got a showcase next month that's going to talk about some of those projects, which we're really excited about, and hopefully you can join us for that. And we've also got a few little resource booklets and bits that we can provide you with as well on our website. If there are any other genomic bites you'd be interested in us putting on, or in fact you would like to teach one of them, then please do get in touch with us, because we're really keen to know what your needs are and how we can support you. Other than that, thank you for joining us, and we hope you managed to eat a sandwich as well as learn some really valuable information. And thank you so much, Chloe, for your time.